We're going to get started. Okay, so I'm going to be introducing our next speaker, Dr. Nguyen. So Dr. Nguyen is a clinical pharmacy specialist who practices inpatient infectious diseases and antimicrobial stewardship at the University of Chicago Medicine. Dr. Nguyen received a Doctor of Pharmacy and completed a PGY1 pharmacy residency at the University of California, San Francisco Medical Center. Subsequently, she completed a PGY2 diseases pharmacy residency at the University of Michigan Medicine, and her primary research interests include assessing the impact of antimicrobial stewardship interventions on antimicrobial use and patient outcomes. So thank you, Dr. Nguyen.
Thanks for that introduction. Can you hear me okay? It feels kind of, I sound kind of weird, but hopefully I sound normal to you. I sound like I'm listening to a recording of myself. It is horrifying. All right. So today I'll be going over oral antibiotics for serious infections. I do have some old consulting experience with Roche Diagnostics, but it's not active and it isn't relevant to today's talk. I'm going to start the presentation by going over the pros and cons of oral and intravenous antibiotics. Then I'm going to slide into some of the data regarding gram-positive and gram-negative bloodstream infections. I'm going to review some of the older published data a little bit on a broad scale, and then dive a little bit more deeply into the more recent data. And then I'm going to end with some strategies that we can use to promote IV to PO step-down therapy for severe infections at our hospitals. So as I'm sure you're aware, there are many advantages to oral therapy. A lot of this has been published. The primary of which is to avoid central line related complications like hematoma, thrombosis, and infection. These relate to a lot of patient morbidity and then also readmissions as well. So those are always good to avoid if we can avoid it. There's also been data published regarding the reduction in pharmacy administration or pharmacy preparation and dispensing time. And then I think actually just a week or two ago, there was a nice study published regarding how much waste can be avoided if we change from IV to PO. So I wasn't able to cite that here, but I think it was just published a week ago. I think over 100,000 grams of waste can be saved if we convert patients to PO therapy. And then Dr. Pogue earlier today mentioned this presentation at ECMID, where nursing administration time is greatly reduced for an oral antibiotic compared to an IV antibiotic. So one dose of an IV medication takes 22 minutes for a nurse to administer, whereas an oral medication just takes 1 minute. So a TID IV medication can save a nurse 1 hour, and that could be 1 hour doing nursing stewardship, right? And so that's a lot of time that can be better spent. There's also a lot of data regarding reductions in hospital length of stay, and then also associated reductions in cost that kind of relates to all of this. And then probably most importantly is improvements in patient satisfaction. Oral therapy allows patients to go home earlier. They allow patients to go to work. And patients, when they're at home, they don't have to be spending time dealing with their IV antibiotics. So in a survey of over 200 patients getting OPAT, patients reported taking over 1 hour, or 55% of patients reported taking over 1 hour a day, just administering their own antibiotics. And 23% of patients said it takes them over 2 hours of their own time. And interestingly, this survey also looked at adherence rates. I think a lot of us assume that if you give them an IV antibiotic, they're going to automatically be adherent because they're delivered, the medicines are delivered regularly, patients are going to be able to administer it themselves. That's not always the case. This survey found that patients with more support and have lower or who have higher income status were actually more adherent. So there are some interesting equity and considerations as well when we're giving IV versus oral therapy for patients. And so what are some of the advantages to give IV antibiotics? And the first one that comes to mind is that you get reliable serum concentrations. You don't have to worry about bioavailability, and you get high concentrations typically because, again, you don't have to worry about bioavailability and assuming patients can absorb therapy well. And I try to look through the literature to see, what other advantages to IV therapy are there, but I wasn't able to find too much. And so I had to draw upon some of my personal experiences rounding on services and reaching out to people. And so what are some of the things I'm hearing? I'm hearing IV therapy is a lot stronger. It's what we do. I also hear I'm more comfortable with IV. And then interestingly, several times I've heard, well, the patient really needs to go to an LTAC. And the only way we can get there is if we give them IV antibiotics. And so IV antibiotics is their ticket to, more acute care services. And so I'm sure you've all heard of a few other interesting reasons as well. They may not all be based in science or evidence, but perhaps, maybe the literature is biased because it's being published by people like me, or maybe I'm biased because I'm a big proponent of Idph step-down therapy. So I try to think outside the box and think, okay, well, let me try to figure out why other people might be wanting to do IV therapy. And so I decided to ask ChatGPT why people favor IV over oral antibiotics for severe infections. And I actually didn't ask ChatGPT myself. I'm a little scared of AI, so I asked my friend who has an account to do it. And so it gave this really actually robust response. I only summarized it here. It gave these 6 bullet points. And then after each of these bullet points listed, I had 2 or 3 sentences to kind of back it up. I didn't ask for references, so it wasn't referenced. So the first 2 I completely agree with: rapid and reliable delivery, and we kind of touched upon that already, and then poor oral intake or GI issues. So for this talk, and hopefully in your practice, you're not giving oral antibiotic therapy for patients who have GI issues or can't absorb antibiotics. So that I agree with. It's really important to select the right patient. 3, enhanced monitoring and control in a healthcare setting. I think this is true to an extent, but for most of the time, when we're stepping down to PO therapy for severe infections, we're maybe preparing for discharge or the patient is a little bit more stable. So that enhanced monitoring isn't always needed. And then if it is needed, well, we're going to monitor them just as well as we would inpatient if they were on IV or oral therapy, right? And so maybe we're even monitoring them a little bit more closely because we just stepped them down. We want to make sure that they're not going to become febrile again or something like that. And so I think that number 3 is important in some aspects, but maybe not in that super acute phase, because in a lot of the publications I'll be talking about, most patients will start with an IV lead-in period and then step down to oral therapy after they meet stability criteria. And then the final 3 listed here: higher drug concentrations, optimal bioavailability, and flexibility in dosing. I think that those are true, but really it depends on the antibiotic. Not all oral antibiotics have these same issues, and we'll be talking about that shortly. So I think a lot of the reasons why people favor IV over oral therapy is because you have to take time to select the right patient and select the right oral antibiotic. But I think that time is very well spent, because stepping down to oral antibiotic therapy is evidence-based practice, because there has been no prospective study that has been shown that IV is more effective than oral therapy. On the flip side, there are several randomized controlled trials that demonstrate that oral is non-inferior or even better, depending on the clinical outcome that's being evaluated, than IV therapy. And so this is really the way that we want to be practicing, because it's non-inferior, it's much more patient-centered. There are many more advantages to oral therapy than IV. But of course, I just want to make sure that we're all on the same page. And so for my presentation, I want to make some assumptions and level the playing field. That again, we're only giving oral antibiotics to patients who are able and willing to take oral therapy and who can absorb, and then making sure that we can manage any drug-food or drug-drug interactions. And I know that this assumption, it's easy for me to throw up on a slide, but it's much harder to ensure in clinical practice. It takes time to talk to patients and educate them on the importance of taking an oral medication. And evaluating the patient's absorption is not always easy either. I have tons of patients on TPN or have parts of their intestines removed, and we have to think about those things too, for sure. But for the purpose of this talk, when we're talking about oral step-down therapy, we're going to be talking about choosing the right patient. All right, so let's jump in. We'll start with talking about how heterogeneous this group of oral antibiotic therapy is. And so not all oral antibiotics are created equal. And I know some of my pharmacists are gonna cringe when I call these specifically highly bioavailable antibiotics, but I think traditionally these have been thought to be the most highly bioavailable antibiotics. So our fluoroquinolones, linezolid, trimethoprim sulfamethoxazole, and metronidazole. And this is because it doesn't matter if you give them IV or PO, the amount that gets into the bloodstream, the exposure is the same, as long as you're giving, sometimes for like Cipro, we give a higher oral dose, for example, like instead of 400 milligrams, we'll give 500 milligrams. But you can see that the exposure, IV or PO, is the same. And so the bacteria circulating in the blood doesn't know if it got there by plane or train. It got there and it's in full force, right? And so for these agents, it doesn't matter as long as the patient can absorb. And so that's great that we have some of these. So IV fluoroquinolones and trimethoprim sulfa are equal. But the issue is that we can't always use our fluoroquinolones and trimethoprim sulfamethoxazole. We have resistance that's rising because of lots of fluoroquinolone use. And then obviously we're obviously sensitive to a lot of the adverse drug events that are associated with trimethoprim sulfamethoxazole. So what about our tried and true beta-lactams? And these are often susceptible, but here's where it gets a little bit tricky. Not all beta-lactams, oral beta-lactams, are created equal. And so I'm just going to talk about this like kind of in a meta way, and then I'm going to like put up a really crazy slide. So if you think about IV versus oral antibiotics for beta-lactams, you have to think about simply thinking two things: bioavailability, which is just the percent of the dose that gets into the blood. And so a highly bioavailable drug, a lot of that dose will get into the blood, right? A low bioavailable drug, not a lot of the dose will get into the blood. There are very highly bioavailable beta-lactams. Even though we don't traditionally think of them as highly bioavailable antibiotics, there are highly bioavailable beta-lactams, but there also are very low bioavailable beta-lactams. So coupled with the bioavailability, you have to think about the dose. And so let's think about how much of ceftriaxone or cefepime we give to patients. We give patients 2,000 milligrams of ceftriaxone or cefepime, right? Compare that to maybe 300 milligrams of cefdinir or 500 milligrams of cephalexin. That's already reducing it by half, right? The dose is already reduced by half. So even if you get 100% of that dose into the patient, it's already going to be lower than what you're giving to the patient IV, right? So you have to think about bioavailability and dose with beta-lactams, right? So if you don't like my colorful boxes and you want data, here are some numbers. All right, so the top few rows are oral antibiotics or oral beta-lactams, and the bottom are IV, and some common doses that we use. You can see that there are some oral beta-lactams that are extremely highly bioavailable. Cephalexin has up to 100% bioavailability. Comparatively, cefdinir and cefpodoxime have really poor bioavailability. Taking that into account with additional pharmacokinetic properties, you can see that the Cmax for these agents are in the teens. So the maximum concentrations in the blood are in the teens for these oral beta-lactams, compared to the hundreds for the IV versions. So you can already see that that dose and bioavailability interplay working out in what the actual exposure is. So beta-lactams work by the pharmacodynamic property time above MIC. So in a given day, you want 50% of the day, so 12 hours of the day, if you draw your patient's serum concentration, you want it to be above the MIC of that organism. So if the goal is 50% time above the MIC, just keep that in mind, we'll do 50%. Here are some oral antibiotics in common doses. I know that some of these doses are a little bit more aggressive than maybe what we commonly use for UTIs, for example. amoxicillin clavulanic acid, 875Q8, or cephalexin, 1 gram Q6. And then at the top here, the 16 to 0.25, those are MICs. So what this review article did was they mapped out some population pharmacokinetics and calculated the time above MIC. And again, we want to do over 50%. So filling in this table, based on, again, population kinetics, you can see that the likelihood of the probability of target attainment isn't always achieved for the higher MIC organisms. So perhaps for cephalexin and amoxicillin clavulanic acid, those are the ones that you get closest to. Again, the number in the box, we want as close to 50% as possible. So half the day above the MIC. But if the MIC is lower, then the likelihood of target attainment is higher, right? And so we don't always get MICs for our oral antibiotics. You know, in your susceptibility profile, you probably see like mostly ceftriaxone, cefepime. Maybe you'll see a cefazolin. Maybe the MIC, if your hospital might do a Curry-Bauer disc, maybe you'll see some lower MICs. But often our MICs that we're getting are for our IV versions. We don't get MICs for our oral antibiotics or susceptibilities for our oral antibiotics. But based on surveillance data, most E. coli have MICs to oral beta-lactams around 4 or 8. And then for streptococci, MICs are usually 0.25 or less. And so you can see that depending on the organism, your likelihood of achieving this target may be higher than not. And I point those two organisms out because those are going to be the ones that we're kind of focusing on today. So the first thing, so I spent my talk into gram-negative bloodstream infections and then gram-positive bloodstream infections. So let's jump into gram-negatives. All right, so let's take a quick poll. We're just going to raise hands. So in a clinically stable hospitalized patient with resolved bacteremia that's secondary to pyelonephritis, would you be comfortable using oral antibiotics to complete a course of treatment for bacteremia? Raise your hand if you say yes routinely. All right, keep your hands raised. And then raise your hand if you think yes, but in special circumstances only. Okay, so maybe like 80% of the room raised their hand, and then a few more when we said yes, but in special circumstances only. And the reason why I asked in the question like this is that there was a study published that surveyed pharmacists and physicians, and they asked the question just like I did, and they compared ID clinician responses versus non-ID clinician responses, and 100% of ID clinicians said, yeah, I would step down to oral therapy for bacteremic pyelonephritis. And then a similarly high rate of non-ID clinicians said the same thing, but more of the non-ID clinicians said in special circumstances only. So in a few minutes, I'm going to be going over some of that data that makes so many people comfortable with this. So just to set a foundation, 47% of bloodstream infections in the US are due to gram-negatives. This is commonly due to a urinary source, so UTIs, intra-abdominal infections, or some pneumonias. And then common organisms are Enterobacterales, like E. coli, Klebsiella, and then maybe in the hospital, Pseudomonas aeruginosa are non-fermenters. Typically in the past, we've tended to gravitate towards PO step-down with a fluoroquinolone or trimethoprim sulfamethoxazole. But again, with resistance rising and adverse drug events, we've kind of started to steer away from these two agents. So this is my brief overview slide. There's been a lot of published studies. I can't go through them all, but there have been many published studies. Most of them are retrospective and observational. Most of the patients that end up being included in these studies just have uncomplicated gram-negative bloodstream infections. It's usually due to E. coli, urinary source, or an intra-abdominal source that has had good source control. And the treatments, depending on the study you're looking at, varies. Some studies compare IV only to IV to PO after a certain set of days, like 3 to 4 days is usually what people feel comfortable stepping down to PO therapy. Other studies compare highly bioavailable to low bioavailable. And if you ever run across one of these studies, I really urge you to read the definitions because, again, high bioavailability agents and low bioavailability agents, there's no standard definition to this. And so it's really important to look to see, hey, did they include a highly bioavailable beta-lactam in their highly bioavailable arm, you know? Looking at it overall, most people do step down to fluoroquinolone if it's available. And then less commonly, beta-lactams have been used in the past. And when beta-lactams are used, the selection is variable. It's all over the place. People are using ceftonir, cephalexin, cefodoxime, and then the dosing is often not reported, or it's, again, all over the place. It's really hard to report dosing retrospectively. Because a lot of it varies based on renal function. So it's really hard to interpret as well. But the review article, the meta-analysis that's cited here kind of goes through it. And this meta-analysis actually looked at 8 of those studies. And they compared oral fluoroquinolones with trimethoprim sulfamethoxazole versus oral beta-lactams. And they found no mortality difference. And again, this is in that common patient population, mostly uncomplicated E. coli bloodstream infections due to urinary or a controlled intra-abdominal source. But interestingly, they found more recurrence, including recurrent bacteremia with the same organism with the beta-lactam, oral beta-lactam step-down versus fluoroquinolone step-down therapy. And a lot of beta-lactam lovers or fluoroquinolone haters are going to look at this and say, well, that's not fair. The beta-lactams, they probably use like a bunch of ceftonir, and that's not a good beta-lactam. Like, if they had used all high-dose augmentin or all high-dose Keflex, it would be a different story. And it might be. We don't know that. We don't have that data yet. But there is a concern with increased recurrence of beta-lactams. But I think that based on the PK data that I showed, and then some of the data that I'll show shortly within maybe better quality data, I think in certain scenarios, beta-lactams can be used, especially if our traditionally highly bioavailable agents are not available. And so you may be familiar with this study. It's a randomized control trial. It's multi-center. It's actually a duration of therapy study. And this is also another confounder in a lot of our retrospective studies because we don't know how long we're supposed to be treating gram-negative bacteremias, especially uncomplicated gram-negative bacteremias. So if you're stepping down to oral therapy at 5 days, and then you're treating with orals for another 2 to 9 days, who knows if that extra oral therapy is even necessary? Maybe placebo would be just as fine. So it's hard to tell, and it's hard to uncouple these two issues with gram-negative bloodstream infections. I mean, I'm not complaining. I think that it's great that we're tackling these two dogmas. It's really important to try to figure these things out. But it's just another thing to consider when you're reading these studies. But this is a randomized control trial that really focused on durations of therapy. And so they randomized over 600 patients to either a short arm or a long arm group, so 7 days versus 14 days. And this is from day 1 of active therapy. So it's not this like first negative blood culture stuff that we do sometimes or all the time. So they included, and in this study, it was, again, mostly uncomplicated gram-negative bacteremia. E. coli was the most common, and then urinary source or intra-abdominal source. Their primary outcome was a composite outcome of a bunch of bad things, and they found no difference between the two. And I'm kind of briefly going over this because it's an older study and you may already be familiar with it. They looked at, durations of therapy. They allowed the treating physician in the study to choose whatever antibiotics they wanted. So they could step down to PO therapy, they could continue IV, they could start with a carbapenem, they could start with a fluoroquinolone, they could do whatever they wanted because this is the duration of therapy study. But in the supplement, they do include some information about what the patients received. And you can see that a minority of patients or very few patients got the entire course with IV therapy. Actually, most patients were stepped down to oral therapy, including 64% of patients in that short arm group were stepped down to oral therapy. So if you're using 7 days of therapy, you can step down to oral therapy and still use 7 days of therapy. Unfortunately, the supplement and the study didn't tell us when that step down occurred. So you don't know if it was just like 1 day of step down or 2 or 3 days of step down. We don't have that information. But you can see that when they did step down, most patients received a quinolone followed by beta-lactams. And then interestingly, there were a few patients who got oral fluoroquinolone for their entire course. So there was no IV lead-in period at all. There was another randomized open label clinical trial that was presented at ECCMID this past year. It's not published yet, but do look forward to when it is published because this data that I'm presenting is not yet peer reviewed. So definitely when it's published, check it out and make sure nothing's changed or see what changed. But so this study was in adult patients. They included patients who had monomicrobial enterobacterialis bloodstream infections with adequate source control. The patients also needed to meet some stability criteria, including being afebrile for over 48 hours when they were being evaluated. They also excluded a number of patients, including patients who were neutropenic and who had a solid organ transplant or stem cell transplant in the 90 days prior. They screened a ton of patients with gram-negative bacteremia, but they had to exclude like almost all of them. And the main reason for exclusion that they reported during the presentation was patients were ineligible because they weren't afebrile for greater than 48 hours at the time of evaluation, unfortunately. So they ended up only randomizing 174 patients. So these patients, again, the provider got to choose which antibiotics they were going to use for IV and oral therapy. And this is really interesting because most patients ended up receiving a beta-lactam. So in the IV arm, I mean, that's not a surprise. Most patients get IV beta-lactams when they hit the hospital. But in the oral step-down group, 65% of patients were stepped down to an oral antibiotic, including 35% of patients receiving a cephalosporin and 30% of patients getting a beta-lactam, beta-lactamase inhibitor. I don't have any additional details regarding dosing or which ones, but I'm really looking forward to seeing that piece of it because I think that having this in a randomized controlled trial will be pretty powerful. And again, same deal, mostly urinary tract infections, a lot of E. coli and Klebsiella. And they looked at their primary outcome was treatment failure. Again, another composite of a bunch of bad things. And they found no difference, the non-inferiority margin of 10%. When you look at the breakdown of the different composite outcomes, there was nothing statistically significantly different, and the numbers are too small to really draw any major conclusions. But you will note higher patients or more patients in the IV arm needed additional therapy, and then more patients in the oral arm needed or required an infection-related readmission, but again, these weren't statistically significant. What was different was the length of stay. So the length of stay in the oral group was shorter than the IV group. So overall, looking at this data, there are many retrospective studies, a few randomized control trials. They all kind of show that oral antibiotics, when grouped together, it's probably non-inferior. We can do this fine. But the data regarding like which one to step down to is kind of muddy, a little bit unclear. We also don't often get the organism MICs. We don't get information about dosing and all of that jazz. And then again, the big confounder being the optimal duration of therapy for gram-negative is being unclear. So what are you going to do with all of this? And so you may be familiar with this study or this consensus guidance. How many of you guys have seen this? Great. So this is what we actually modeled our institutional pathway off of. And it was published in 2019, but even with all the new data that's being published, I still think it's, it holds strong. It's withstands this test of time. And so Heil and colleagues published this guidance document. It's really great. It kind of reiterates everything that I've been kind of saying because it's based on a lot of that published data. But if you're looking for like a kind of a one-stop shop to figure out like what to do in this setting, I think that this is a really good document to reference. So they provide definitions for uncomplicated gram-negative bloodstream infections. Also, outline which patients are eligible for oral step-down therapy. And then they also say, hey, you should use 7 days for most infections. We took this document and we presented it to our our ID group. We tweaked it, based on people's comforts and feelings, and then made our own pathway out of it. But what I really like about this is that they provide recommendations for oral antibiotics to step down to, including dosing. And dosing is so important, not just because I'm a pharmacist, but because if you're going to give someone an oral antibiotic, you want to give like not just a homeopathic dose. You want to give like a real dose, So some of these are maybe a little bit more aggressive than you are used to, right? So Cipro 750 Q12 or amoxicillin, a gram Q8. And so I urge you not to skimp on the dose. A lot of people are like, well, the patient's not going to do Q6-hour dosing anyway. I'm just going to do it TID. It's more realistic. But talk to the patient, let them decide if they're going to skip that dose or not. Like, don't make the decision for them, right? So, I mean, I don't think, when we used to use oral vancomycin all the time for C. diff, no one batted an eye giving it, oral vanc Q6 for all their C. diff patients. But, we got so nervous with Q6 Keflex, and the patients have these are real bacteremias, right? It's like you have a serious infection, you have to take a 4 times a day medication. Maybe it's better if you can shorten the duration a little bit, right? It's only going to be for like 3 more days. Just please take all your antibiotics and avoid being readmitted, So I think it's really important to just try to make people feel more comfortable with using these higher doses. And again, if you recall the PK data, these doses aren't even they're not giving toxic levels in our patients, right? People would, I've never used a gram Keflex. And it's like, you're using 2 grams of ceftriaxone right now in your patient. You're getting a lot of antibiotic in your patient. All right, so let's move on to gram positives. All right, so gram positives are super heterogeneous. Staph aureus, enterococci, streptococci. They live all over different parts of our body. They cause different infections. They're not like the Enterobacterales that I just presented that commonly cause kind of the similar uncomplicated infections. The common sources of infection vary based on pathogen. In the interest of time, I'm only going to focus on streptococci. And this is because I think that we're a little bit whiles away from like stewardship programs really taking on IV to PO conversion for Staph aureus. And then enterococci, there's just not a lot of data there. But I do think streptococci is important because we have seen, and I'm sure you guys have all seen the alerts, an uptick in invasive streptococcal infections, right, including bacteremia. So I do think this is relevant, and it's good to go over the data. So again, a very verbose poll, but in a clinically stable patient who's hospitalized with resolved bacteremia secondary to a defined source, would you be comfortable using oral antibiotics to complete a course for strep bacteremia? Yes, routinely? Not a lot of hands. Okay, yes, in special circumstances only. Okay, so a few in special circumstances only, but not a lot of yes routinely. So interestingly, this survey, again, over 200 pharmacists and physicians, split it up into ID versus non-ID. Again, most people were comfortable stepping down to oral therapy for streptococcal bacteremia, but you'll see that a lot more ID clinicians are saying in special circumstances only. And I think this is because we're thinking about all the nuance. You're like, well, what about strep endocarditis? Like strep pneumonia, bacteremic strep pneumonia. People are like, okay, I can do that. But again, it's a very heterogeneous disease state. And so let's go over some of that data. So these are all, or not all, these are some of the retrospective single center studies. And, this is what I was able to find, and I kind of cherry picked these, but I think it's kind of interesting. It compared IV only to IV to PO step-down therapy for uncomplicated streptococcal bloodstream infections. And you can still remember what retrospective data is. It's just looking back at what people are doing, right? And so people are already stepping down to oral therapy for this. So you can see in each of these retrospective studies, about half of the patients are getting the IV to PO step-down therapy already. Like, this is in the past. And interestingly, different from gram negatives, a lot of them are getting oral beta-lactams here. Even that first one, a lot of patients get oral ceftonir, which may be a little scary to some people. And then in terms of source, it's kind of all over the place, but the common sources we usually see are skin soft tissue, pulmonary, and intra-abdominal infections. These are all different strep species, right? Because you're imagining like, oh, pulmonary, like so that's strep pneumo, viridin strep, So all these other, so that kind of accounts for it too. So there's a little bit of heterogeneity in there. But what I wanted to point out with the source is that in the Kang and the Ramos-Otero study, the most common source of infection was unknown. And a lot of times when I'm in practice, when something's unknown, we're like, we're not playing around with this. Like we're giving the strongest thing that we have because we don't know where it's hiding, right? But interestingly, a lot of people are using Idph step down, and they're doing fine. All these studies show that clinical failures were no different between the two groups. Ramos-Otero found that clinical failure was higher in the IV arm, but that may be due to some selection bias. IV patients are more sick or have more severe infections, so they stay on the IV therapy. But no difference in clinical failures. And then the length of stay was shorter in the IV to PO arm for all of these, again, single center retrospective studies. All right, I wanted to put this up there. Anyone from Advocate here? Any Advocate? Well, this is from our neighbors, a multi-center study in Advocate, Illinois. So they all teamed up and they did a retrospective study comparing oral step-down therapies. So all these patients got an IV lead-in period, and then they either stepped down to an oral fluoroquinolone or an oral beta-lactam. And so, again, we want to know, does it matter the agent that you choose? You can see that a lot more patients here in this retrospective study got that oral beta-lactam. And most patients were treated for 14 days. And in that oral beta-lactam group, most patients received Augmentin. But again, a lot of heterogeneity in that group. The sources of infection was also different between the two groups. You can see more patients in the fluoroquinolone arm had a pulmonary source of infection. In this study, most patients also had an ID consult, and most patients had bloodstream infections presenting from the community, so a lot more community-acquired infection. They're the only optimists that I'm presenting so far. They looked at clinical success instead of a bunch of bad things. They looked at good things. So not over 90% of patients in each arm, no different between the two arms, had clinical success. And so I think this is a lot of good data to say like, hey, we've already been stepping down oral therapy. We've been using some beta-lactams. We're using our brains. We're choosing the right patients. Our patients aren't dying. We're okay, right? And so, you can poke holes in this. You can say it's uncomplicated infections, and that's fine. So let's talk about some severe infections, right? What about endocarditis? Who's using oral therapy for endocarditis? No one, okay. So this study was POETS. I'm sure you're very familiar with it. I will just briefly go over it. So this was a randomized control trial looking at left-sided infective endocarditis due to typical endocarditis pathogens. They randomized patients to receive IV or oral therapy after an IV lead-in period of 7 to 10 days. Patients also had to meet some stability criteria. And the reason why I wanted to talk about this was because 50% of the patients in this study had streptococcal infective endocarditis. And so I think that that's relevant. Obviously, it's not powered to just look at streptococcal endocarditis alone, but in the subgroup, the primary outcome was no different. This data here is the total population, but notably, the study did mention that the stratified by organism, there was no difference in the primary outcome as well. So if you look at the study, you can see that in the oral arm, most patients got amoxicillin, either with rifampin or moxifloxacin. And then a recent sub-study of POET was published. And so when patients were enrolled into POET, there were some patients that got serum concentration monitoring. So on day 1 and day 5, these POET patients got their blood drawn like 4 times on day 1 and 4 times on day 5. And so this sub-study was recently published. I'm only showing you the strep data, but they have the data for all the other organisms too. So if you're interested in this, check out the study. But they took this, they had to make some population assumptions, like in terms of protein binding. Obviously, they had to choose their target, to attain. But you can see that these are real patients, real MIC or clinical isolates in their MICs, and they're real concentrations of exposure of these antibiotics. And you can see that on day, so blue is day 1, 5 is day, or red is day 5. And so amoxicillin and linezolid, the probability of target attainment on both days was extremely high, 100% on both days. So we're meeting our pharmacokinetic targets for those. There was a little bit more variability with moxifloxacin and rifampin, but the probability of target attainment for those was still above 70%. And so I think rightfully, the authors say, PK and target attainment isn't everything. Right? If you think about it, there's so many other things that predict clinical success for endocarditis. Surgery probably being the number one thing if a patient really needs it, comorbidities, things like that. And so if you can optimize PK, PD, that's great. But again, it's really hard to say, this is the end all be all, for your patient. But it looks like amoxicillin and linezolid for streptococcus, I remember that those MICs tend to be lower. We were able to achieve that, our typical PK targets. They also say, like, maybe some of the lower probability of target attainment can be mitigated with combination therapy. So for severe infections, you may see some combination therapy being recommended for when you're using oral therapy. And so now we have a lot of retrospective data, we have some randomized control data. We even have PK data in real sick patients where we got actual drug levels. And so I think we're probably all ready to use oral antibiotics for endocarditis now, or maybe not. I think for me, I'm a little bit hesitant still. To be honest, I want someone else to do it first and make sure that they don't, they don't get sued, or they don't, but it would be really nice to have a guideline say, like, this is oral therapy is recommended first line just as much as IV therapy. Right now it's just like carve it out in a special population. I just don't want to be the first one. So then we're like, okay, well, maybe I want someone else to do it and publish some more retrospective data. Like, I love me some retrospective data. So someone's starting to do it. Okay, so this is recently published. It's real world data. So 3 LA, Los Angeles County hospitals got together and they're like, we're going to try to take on IV to PO for infective endocarditis. And then they got together, they published this study comparing IV only therapy versus IV to PO step down. And I know what you're thinking. You're like, there's going to be so much selection bias in this. Like, there's no way that I'm going to get any helpful information from this. And you're totally right. So one way they try to mitigate this is through their use of expected practices. So expected practices is, so across the LA County Health System, they have this top-down guideline, essentially, and they say, this is our standard of care, and you should do it. And they even have this disclaimer at the top that says, like, if you're not doing an expected practice, you should include some compelling documentation in the electronic medical record. And so I was like, what is this? When I was reading it in this study, I reached out to some of my colleagues and that kind of work in these health systems. I'm like, are these just like glorified guidelines? How's it different from like the one that I make a Word document on my computer and post it on my internet? And they're like, in some ways it's the same, in other ways it's not. So yes, they're guidelines, but they are, again, top down, so they're across their health system, and it's meant to try to standardize and make care equitable, but they don't monitor it, and there's no repercussions if they don't follow it, not for the endocarditis one at least. But it does provide a shield and comfort for providers that say, hey, I know the data is strong for endocarditis. I know there's no prospective randomized trial to say that I have to do IV. I want to do it. And this provides them with some comfort in saying, and it says, this is our standard, and I think that goes a lot, kind of pushes the boundary. And so they made one for infective endocarditis. The verbiage is soft. So patients with infective endocarditis may be switched or may be considered for switch to oral step-down therapy when all the criteria are met. There's not a lot of criteria here. So the patient's clinically stable with no immediate need for surgery. the patients clear their bacteremia, they can take oral therapy, and there's no psychosocial reason to need IV therapy. And that's it. And if you're going to use orals, they say you should use one of these evidence-based regimens. This is a really cool supplement. So if you're interested in kind of like checking out like the ins and outs of what they do, just go to their supplement, like download it. They have all of the regimens listed, and it's like cited really nicely. This is again just for streptococci, but they have it for Staph aureus, enterococci, etc. So for penicillin sensitive streptococci, for native valve, they say you can use high dose amoxicillin monotherapy, but you can see for the others, they do encourage combination therapy. Again, this is just for streptococci, but the expected practice has oral regimens outlined for all the other organisms as well. So the study that they published, they evaluated 257 patients. You can see that probably like only a quarter of them or less got IV to PO step-down therapy. So even with the expected practice, there's not a lot of uptake here. It's still quite a select population. And that is very evident when you look at some of the baseline characteristics. So it's nowhere near a randomized controlled trial. You can see that patients who were younger and who had injection drug use were more likely to get oral antibiotic therapy. Patients with hardware, including a prosthetic valve, a pacemaker, ICD, and then patients with central venous catheter were more likely to get IV therapy the entire time. There was no difference for patients, if they had definite versus probable or possible endocarditis. Stable housing didn't play into decision making. And then there were also some differences in obviously the valve type that was infected and other patient baseline comorbidities, but I didn't include it here. But definitely we're not comparing apples to apples. The most common organism was Staph aureus. And so the most common oral antibiotic use was actually linezolid for this study. And then the second most common was streptococci, and high dose penicillin was used as the second most common oral regimen. So looking at their primary outcome, there was no difference in 90-day clinical success. You can see the composite endpoints listed there, and there's no difference in those or readmission. And then total adverse events was higher in the IV group, and this was driven by acute kidney injury and line-related complications, actually. There's no difference in cytopenias either. I don't have that listed here, but it is listed in the study. Length of stay was no difference between the two arms, and most patients actually stayed on IV during their entire hospitalization and only stepped down to oral therapy when they were discharged, which I think, tracks. And then the duration of therapy was no different between the two arms either. A lot of people are concerned about, compliance or loss of follow-up with the oral therapy arm, but they didn't see that in this study. So, I don't think that this is a perfect study. It's not a randomized control trial, but, POET was published and no one really cared about that. So this is I think that this says like, hey, if you use your clinical judgment and you pick the right patients, it's fine, so maybe we can start carving out some of these patient populations and think about, starting somewhere, right? Because we know that oral therapy is just as good as IV, but we need to start somewhere and start pushing our comfort zone. So just to summarize the data so far, it's really hard because there was a lot, but overall, a lot of retrospective studies, a lot of randomized controlled trials too. The verdict is still out on which oral regimen is best, but seems like if you can get a highly bioavailable one and also consider the PK/PD targets in relation to the MIC, that's really important to try to optimize that. And then still the uptake for IV to PO step-down for very severe infections is slow, but a lot of people are doing it for uncomplicated infections with success. So let's talk about putting it into practice. I'm just going to kind of try to speed up a little bit. So should we do it? Yes, we should. There are 2 guidelines that say we should. So so why don't people do it? We need to know the barriers. So all knowing, let's ask ChatGPT what the barriers are. And I found this actually extremely fascinating and scary. So like, this is verbatim, I just copied. So why don't more prescribers use oral antibiotics for severe infections versus established clinical practices? So, prescribers are only following the guidelines. The guidelines say use IV antibiotics, at least up front. The off-ramp is always kind of hard to identify. But they say these guidelines are often based on historical practices, which may take time to change, even in light of new evidence, right? And this is so true because it's a dogma, right? This IV for all, there's no prospective trial that says we must do this, but it's what we've been doing. And now it's our job to find the most robust data to try to debunk this practice that we created. And so it's going to take time to change. The next two barriers include perceptions. So perception of severity. And this is ChatGPT. I'm not saying anything here. They're saying like prescribers are perceiving or they feel more comfortable with IV antibiotics, and they perceive that patients won't be compliant. But we know that compliance is not guaranteed with IV antibiotics either. So and then the final one is lack of awareness or familiarity. So it's difficult to stay up to date, and disseminating new evidence takes time. So I mean, I think you can break this down to say, our jobs as stewards will be to educate and to change the culture. And so change culture and perception, that's going to be hard. But how do we do it? First, let's start with education. And people need to know, the background, the data. Maybe people know it, they just don't feel comfortable using it. I mean, I know the POET trial and I know all this PO data, but I'm not out there like vying for PO step down for endocarditis right now. So I think the way to change culture, and I'm not like the expert or anything, but I think the way to change culture is I like to go for the quick wins. Go for kind of the low-hanging fruit, talk to providers one-on-one. As humans, we remember our failures so much more strongly than our wins. And so if how many times I've been burned before doing that. It's like that sticks for years. That provider will remember being burned and not, replay that scenario again. And so if I meet hesitation, I'm like, all right, so maybe not, maybe you don't want to do it for this patient, but, just keep in mind for the next patient, this type of patient was included in all the studies. And I think that they would be a good PO step down, but all right, like, because if something bad happens, even, a lot of times patients are going to fail IV therapy too. It's a source control issue, but I don't want to be the blame. Like Cynthia made me do oral antibiotics, like that's not going to happen today. So I'm going to try to do one-on-one and we're going to do the quick wins, right? So like, okay, this is a straightforward case, make you feel comfortable. They're going to see a positive outcome, boost their confidence, and their behavior is going to change because that's what you need. You need that cyclical conditioning effect where they say, hey, my patient didn't die when I did that. They didn't get readmitted. No one yelled at me. No one blamed me. I maybe even got them out of the hospital faster. I didn't have to deal with setting up a line. I didn't have to deal with like setting up IV antibiotics or going to a nursing home, and my patient survived. And the more times that positive change happens, then the more likely they're going to do it for more patients. And so I want to talk about so we published or we developed a pathway. It was a lot of times it was based on the consensus document. We posted on our internet, yada, 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 education parade. All right. So we also did we also have these monthly clinical pearls where it's just a one slide, PowerPoint slide. We push it out to all of the medical residents, pharmacy residents, hospitalists. We encourage them to print it out, post it in their rounding rooms. We made one for the definition of uncomplicated gram-negative bacteremia. We made another one for durations of therapy. Our administrators caught wind of this. They loved it. They were like, hey, this has length of stay implications. This social work was excited. Everyone was excited. And, you kind of like get people excited about it. And so we paired this with prospective audit and feedback. And so as stewards, a pharmacist on the stewardship team reviews all patients with positive blood cultures, and we tried to really focus on the gram negatives. So identifying uncomplicated infections, and then really like focusing on PO step down therapy and durations of therapy. And so again, this is where, we have to, I mean, culture change is hard, you have to just do one at a time. And I think I've had a lot of success. I think we've been doing this for 6 to 8 months, and I could already see my recommendations changing. In the beginning, I called to recommend PO step down therapy, to recommend 7 days of antibiotics. Now patients are providers are already stepping down to PO antibiotics. Before that, before the cefazolin Kirby Bauer disc comes back, they're already stepping down to Bactrim or Ceftonir. And I'm like, oh, let's wait a day and see if we can get the patient on Keflex or changing them to Augmentin. So my recommendations are not just IV to PO. My recommendations are now which PO antibiotic. How do I optimize dose? I see you've already stepped down to PO. Why don't we increase that dose? It's important to give that higher dose. And I could already see them, planning for a short course, because my hospital is really big on like anticipated length of stay, like discharge planning, right? So they're already like planning. Patients not going to need a pick. They're going to be going out on PO. They're not going to need 14 days of therapy. So I can see in the notes that there's already a change, and I think it's really exciting because I can see that the shift. So I can see the mentality isn't okay. We treat bacteremia for 14 days of IV therapy. Who are the exceptions? Now it's, okay, we treat bacteremia for 7 days of therapy. Who are those that need a little longer, right? And so it's that frame shift that's really exciting. And it may seem tedious, to call one at a time, but especially if you have a smaller hospital, if you're working with a hospitalist group or something like that, then it really pays off, right? Because they're there, they're working, they talk to their colleagues, and I think it's really important to do. So I encourage you to continue or start challenging the dogma, changing the culture. But when you do step down a PO, make sure you set it up for success, because you don't want people to get burned or have these horror stories about, failing a homeopathic dose of Ceftonir. You want to identify the right patient, counsel them, select a good oral antibiotic, and then give that optimal dose. So with that, I'm happy to answer any questions or listen to some of your successes. This is the UChicago Adult Stewardship Team, and this is my dog Charlie.
Yes. Do we have any idea of the scope of these, uncomplicated bacteremias when somebody has pyelonephritis? I guess it's difficult to understand that if you don't go looking for that bacteremia. But I get in a situation where they turn around quickly in the emergency department. They got a consolidated dose of ceftriaxone. They get a bolus of fluid. They're not nauseous anymore. They're able to keep things down. Great. You perked up. You're ready to go outpatient. Then the biofire hits, and it's 1 out of 2 E. coli, and they're on a consolidated dose of ceftriaxone, going home on Keflex. What do we think about that situation? Where do you feel confident that you can say, call the patient, here are things to look out for, and ride it out with a oral therapy? Or is that somebody, because we don't have susceptibilities, you got to come back to the ED or IV therapy, 2-step down to oral?
Yeah, a lot packed into that. So I think I can answer your immediate question. It depends on the patient, right? So if they're like a young person that can sure come back to the hospital, yeah, sure, bring them back, right? If they're a patient that has been here often and you can look at their previous susceptibilities and you're like, I don't think you're going to have an oral option or something like, or maybe they're unstable, then call them back. But we do actually culture callbacks with our ED pharmacists quite a bit. And so we have that conversation with the patient, and usually the patients are like, I'm not coming back. We're like, okay, well, we'll follow up tomorrow what the susceptibilities are, and then we'll let you know. And I'm like, or you'll let us know, where to find us, kind of thing, right? And so, if they're not feeling well, I think that they can come back or ask to be brought back. But I think your question in general was kind of like the premise of a lot of this. Like, a lot of women have UTIs. Not everyone's getting a blood culture in clinic, right? How many of these are bacteremic UTIs? Maybe 1 dose of ceftriaxone for an uncomplicated bacteremic UTI is all you need. Again, I presented a randomized control trial with 7 versus 14 days, but maybe the next trial is 7 versus 5 days or 3 days versus 7 days. We don't know what the optimal duration of therapy is. Hopefully I answered your question. Okay. Any other questions or anyone else want to share their experience yet?
Some of the higher dosing available are that is recommended for gram-negative infections. I sometimes find it difficult to find established renal dosing conversions for patients who have some poor kidneys. Do you have any recommended resources for that?
Yeah, I think some of it's challenging. often we look at LexiComp and do like a percentage of the of a dose reduction, but honestly, I always err on the side of being more aggressive. Beta-lactams are very well tolerated, and again, if you look at those the exposure of those IV versus oral, you're not getting nearly the same exposure as the IV therapy. So if they're tolerating 2 grams of ceftriaxone, they're probably going to tolerate 500 milligrams of Keflex just fine, or a gram of Keflex just fine. But I think that that's a definitely valid concern. Yes.
I was going to ask, I guess your point on some of the slides, like you're going to take what you can get to optimize everything you can. You're going to take the beta-lactam with better bioavailability. You're going to take the one that you can dose more aggressively. But then, like, if somebody, and I know it's kind of like maybe a popular thing, like trash and Cefdivir these days, but then, like, when somebody asks about it or they use it, it's like, well, are there studies that show Cefdivir, if it's failing? Well, no, there's actually 7 studies that show that it's equivalent to other beta-lactams and all kinds of infections. Like, how do you rectify that when the PK looks so terrible on paper? Like, I guess there's so many other factors.
Yeah. I think it's easy to like stand up here and say like Cefdivir sucks, but if you're cefazolin, if you have a cefazolin resistance and fluoroquinolone resistance and Bactrim resistance, you're like, well, we got Cefdivir or a PICC line, like essentially, and we're often stuck thinking about that. And I think it's a lot of assessing the patient, getting usually, for my obese patients, I get very nervous about that. Sometimes I say, treat as long as IV as possible. How much longer do you think the patient's going to stay here? And sometimes I end up saying, like, I think we should just put a PICC line in this patient. But maybe if you've already gotten 5 days of therapy in a patient and you just got 2 more days of Cefdivir left, then I think that risk benefit changes a little bit. And I think a lot of it depends on the source and how closely you can monitor your patient. Any other questions? Yes.
I'm going to ask you to comment on the E. coli that are resistant to ceftriaxone, that sensitive to ceftriaxone, what actually makes it.
Yeah, I think that kind of goes towards this gentleman's question. For those patients, if in general, I tend to gravitate towards either the fluoroquinolones or trimethoprim sulfamethoxazole, but I'm assuming based on your question that those are off the table as well. You're like, no, can't use that. Okay, so then again, we have either Cefdivir or cefpodoxime, but we don't have robust PK/PD analyses for either of those two. So again, you're really stuck between a rock and a hard place because you don't want to put an IV therapy in. You don't want to use. You don't really want to use PK.
If the E. coli resistance to the ceftriaxone, because there is when you cannot compare sensitive to Cefdivir.
Right.
You can't step down from ceftriaxone to Cefdivir.
Right. Yeah. So I guess just to make sure that we're all on the same page. So cefazolin is the surrogate for oral antibiotics, for oral cephalosporins. So if you see cefazolin susceptible in your urinary isolate, that's what you should be using to decide if the likelihood of an oral cephalosporin is susceptible or not. And again, this is just in UTIs. If you look at the guidance, there's not that same footnote for surrogacy for bacteremias. We're also inferring for bacteremias that that's true, but that's not technically true either. But again, I think, as a clinician, I round with my patients every day and doing stewardship. We have to make those hard decisions. And I think I don't try to like bamboozle the physician. I'm just like, these are the issues, we have to decide if we're comfortable with this low bioavailability, or if you would prefer to put in a line in the patient. And sometimes they say, well, I would like to put in a line for this patient. And I say, okay, like that's fine. But other times there's like, I don't know, like this seems like a lot for just a UTI, and sure, Cefdivir or cefpodoxime may be fine in that scenario. But again, I'm very upfront with the risks here. And I think that, it's a lot of shared decision making and discussing with the provider in that scenario when you can't say that there's a clear right or wrong answer. So.
Sorry to bring it up to discussion, but we do have to do the